that session, we will have a 20-minute case study by Dr. Hyland as well, and followed by a Q&A portion as well for about 10 minutes. So if you would, during that time, if you have any questions, put them in the chat or wait until the 10-minute Q&A session so we can answer questions and provide any additional information. Okay, so with that, I'd like to introduce you to today's speaker. And let me get her wonderful bio up. Let's see. Okay, today's speaker, Dr. Kelly Hyland, is a licensed clinical psychologist and a tenure-track assistant professor at the Medical University of South Carolina. She is the director of psychosocial oncology research within the survivorship and cancer outcomes research program, at Hollings Cancer Center. Her research aims to develop, test, and disseminate psychosocial and behavioral interventions to improve symptom management and quality of life in growing populations of survivors living longer with metastatic cancer. Very important piece, Dr. Hyland. Dr. Hyland earned her PhD in clinical psychology from the University of South Florida Moffitt Cancer Center. She completed her clinical internship and postdoctoral fellowship at Duke University. She has received grant funding from the National Cancer Institute F32 K99-R00. Dr. Kelly, thank you so much again, and I am going to turn this over to you to present as soon as I get your presentation on the screen.
Wonderful. Thanks so much, Sonia. And I appreciate you advancing the slides for me.
Anytime.
Yeah. While she's pulling that up, really excited to be here to talk to you all. As she mentioned in my bio, I'm actually relatively new to South Carolina. I started my job at MUSC just at the beginning of April, but really excited to be here and talk to you about some of the topics that I find to be most important in caring for cancer patients, specifically attending to psychosocial and mental health needs. Sonia was lovely to read my bio, so I will not introduce myself further, and we will jump right in, as I know I have very limited time. So next slide, please. Great. So there are over 18 million cancer survivors in the United States today, of a very big and growing number. Next slide. So that number is anticipated to grow to nearly 26 million survivors by 2040. So an important population, and these increases in the number of survivors are due to wonderful medical advances, things like increases in our ability to detect cancer earlier, increases and improvements in medical treatments, and improvements in supportive care. And as this image shows here, when we think about the kind of cancer survivorship landscape, it has really significantly changed over the last 20 or so years. And there's no kind of like one face of cancer survivorship. So when we typically, I think about cancer survivorship, we think about the first kind of quadrant of this diagram, which shows our patients that are diagnosed with earlier stage disease and treated with curative intent, who are then living kind of disease-free, right? What we typically think of when we think about a cancer survivor. But there are a growing number of people who fit into this kind of middle domain. So people who are living with cancer as a chronic condition, or people who are diagnosed with advanced or metastatic disease, who are living with cancer, and the goal is not to cure the disease, but rather to control the disease and prolong life. As you can see by these kind of multi-directional arrows, cancer survivorship is also not linear. So you might have a person diagnosed with earlier stage disease who experiences a relapse. You might experience people with advanced disease who have kind of like, recurring periods of stability of disease followed by acute exacerbations of symptoms and side effects. And so whereas the kind of roller coaster, I like to use this metaphor of cancer, used to look somewhat like that image on the bottom, where it was this kind of precipitous decline towards end of life. If you click, please, Sonia. We now have a much different kind of display where the roller coaster is a little less predictable, right? There are many kind of loops and turns, and we don't, people might experience kind of various shades of survivorship over the course of their life. So when we think about what are critical elements of comprehensive cancer survivorship care, there's many elements as we see depicted here, and all of these are very important and interrelated. But today I'm going to focus in on the one that is near and dear to my heart, which is dealing with the psychological effects of cancer and treatment. We know that guidelines recommend that addressing psychosocial care is a critical component of providing holistic cancer survivorship care. And why this is important is we know that mental health is intricately related to overall health. And we know that psychological health is related to quality of life and lifespan. And if you talk to some survivors, I think this is often something that catches people off guard, right? People are often really prepared for the kind of physical side effects, but maybe not so prepared for the psychological impacts. And I've had many people tell me that this was the most challenging part of cancer survivorship for them. Next slide. So we have kind of recognized the importance of attending to psychological health, and the way that the cancer world has chosen to kind of hone in on this is focusing on psychological distress. So distress is defined as a multifactorial, unpleasant experience of a psychological, social, spiritual, and/or physical nature that may interfere with one's ability to cope effectively with cancer, its physical symptoms, and its treatment. Distress does not have to be cancer specific. It does not occur in a vacuum, right? If somebody is distressed about finances or a relationship while they're living as a cancer survivor, that's going to impact their ability to cope. And we know that literature suggests that about 40% of cancer patients experience clinically significant distress at some point in the cancer care trajectory. Predictors of distress include things like disability, poor quality of life, having unmet psychosocial needs, and a history of a mental health disorder. So I'll direct your attention next to this distress continuum in the top right corner, because I think it's important to acknowledge that psychological distress does occur on a continuum, right? So not everything is pathological. So people might experience what we call kind of normal adjustment, which I'll talk a little bit more about, all the way up to kind of diagnosable mental health disorders, which can cause significant disability and really interfere with people's lives. And I think as kind of healthcare professionals, one of our main places where we can be helpful is being able to help distinguish what is kind of periodic normal adjustment difficulty and what is a more serious mental health disorder, so that we can help to kind of triage people to the most important and accurate resources for them. So in order to streamline this process, the National Comprehensive Cancer Network, or NCCN, has worked really hard to establish standards of care, including screening, triage, and evaluation. And about 10 years ago, they actually identified distress as the kind of sixth vital sign. So talked about how, evaluating distress was just as important as things like blood pressure. And the most commonly used tool to assess this is the distress thermometer, which you see in the bottom left here. So this includes the thermometer that we often use to measure pain, so that 0 to 10 kind of single Likert item rating. And then it can be administered with or without the problems checklist on the right here. So people would kind of look at this checklist and yes, no, check off things that are relevant to them. This is really helpful to kind of show you how the severity of distress and kind of where people are experiencing distress. Many cancer centers have worked to integrate this into their workflow, but it doesn't always happen. And if we think about survivorship and, people have various schedules of interacting with the healthcare setting, sometimes it falls through the cracks. And so I think this is a helpful tool for any healthcare professional. It's free, it's available online. You could always administer this to a cancer survivor to kind of get a pulse on distress and sources of distress. There are some recommended time points when I think it's particularly helpful to administer them, as you see on the right here, but really this is something that's important to assess in an ongoing fashion. Next slide. So when we think about the sources of psychological distress in cancer survivors, there are many, right? So some of the ones that I think we more kind of typically think about, cancer-related challenges, things like coping with diagnosis, treatment, making decisions, fears about cancer regression, recurrence or progression, long-term and late effects. People might have concerns about functional challenges like maintaining their independence, the various impacts on life roles, ability to work, etc. Keep clicking, Sonia. Perfect. Physical challenges, often things that we think about. So those kind of more immediate acute symptoms and side effects like pain, fatigue, insomnia, body image concerns, impacts on sexual health and fertility, and then also the kind of ongoing health maintenance and comorbidity management, right? Just because cancer happens doesn't mean that a person doesn't have to manage their diabetes or other conditions as well. And there might be interactions between cancer treatments and care for other comorbidities. Emotional challenges, what we're really here today to focus on. People might experience kind of big and uncomfortable emotions that they are not used to and might have difficulty regulating those. We also hear people talk about just kind of the burnout from ongoing disease management, right? So managing just all of the appointments and things that are related to cancer survivorship can feel like a full-time job. Social challenges, people might feel kind of lonely or isolated from the people around them, even if they are like physically surrounded by people, because they might feel isolated in their experience, might have difficulty communicating wants or needs with loved ones. Practical challenges like finances, transportation, coordinating care can be really distressing. And then finally, the existential, religious, and spiritual challenges. People might have fears of death or dying, might be kind of questioning their beliefs, and might seek to find meaning and purpose in their experience. Next slide. So starting here with kind of normal adjustment, I'm going to walk us through the continuum of distress. The good news is that most patients experience what we would call kind of normal adjustment. I think the most important thing to take away from this slide is that adjustment is an ongoing process. This is this kind of ongoing process throughout the survivorship continuum where a person is trying to manage emotional distress, solve cancer-related problems, and gain mastery or control over their kind of experience. Typically, normal adjustment occurs in people who are able to adjust, right? To do the things listed above, to minimize disruptions in their life roles, to regulate their emotions, and to remain connected to sources of meaning and purpose. One more click. Uh-oh. Perfect. Oh, there we go. So coping is really like how people adjust, right? So it refers to the specific thoughts, behaviors, practices that someone might use to adjust to cancer. What is effective might vary by person, right? So some people might really like to talk things out. Other people like to process more internally. Some people use humor to cope. When we think about what is helpful and what is not, there are typically some strategies that are less adaptive, right? So if someone is turning to alcohol or drugs to cope, that actually might help them feel better in the short term, but as we know, that is not going to be adaptive in the long term. I think importantly, normal adjustment is not smooth sailing, right? But this is the idea that with kind of time, adequate resources, and effective coping strategies, most people are able to kind of adjust to cancer survivorship. Next slide. All right, when we think about adjustment disorders, so kind of the next rung up on the ladder, these are really characterized by the presence of clinically significant emotional or behavioral symptoms that result in marked distress or significant impairment in multiple domains. These symptoms are in response to an identified psychological stressor. In this case, cancer, it could be diagnosis, it could be other aspects of cancer like treatment or clinical turning points, whatever it might be. Next click. Symptoms here are less severe than diagnosable mental disorders, yet, quote, in excess of what would be expected, which is, I think, kind of quite subjective and sometimes difficult to discern, and they do not represent normal bereavement. When we think about prevalence, I think, based off of this definition, it would be justifiable to diagnose any cancer survivor who is struggling to adjust with an adjustment disorder. This is the most common thing that I diagnose people with in my clinical practice. But when we think about the actual kind of rates of adjustment disorder, we know that it's about 20% in people who are on active treatment. And then there are certain clinical variables that are associated with higher rates of adjustment disorder, things like cancer stage, as well as particular types of cancer like lung and lung and pancreatic cancer typically have higher rates of adjustment disorders. Next slide. All right, so next thinking about anxiety disorders. So these are characterized by two kind of classes of common symptoms. Intense worry, which especially in cancer can interfere with someone's ability to absorb information and to cooperate with medical procedures, as well as the somatic symptoms that we often think of with anxiety. So shortness of breath, sweating, lightheadedness, heart palpitations, etc. One more click. When we think about disorders, there are many anxiety disorders that can present in cancer patients: generalized anxiety disorder, phobias, OCD, health anxiety disorder, PTSD, etc. The prevalence of anxiety symptoms is about a quarter of patients, higher in women. The prevalence of actual diagnosable anxiety disorders is about 10% across cancer survivors. And risk factors for anxiety disorders, the predominant one is having a history of an anxiety disorder, having anxiety at baseline, having severe physical symptoms like pain, lack of social support, functional limitations, changes in disease status, and a history of trauma. Next slide. And then before that, I actually love this slide because I think this really helps to characterize how anxiety is actually a normal and adaptive reaction when we are adjusting in a situation that is perceived as a threat to our health or to our life, like a cancer diagnosis is. But I think this helps to show that, not everything is pathological, and that some anxiety or arousal is kind of normal, common worry, but might help us to distinguish when that tips over into something that's a little bit more pathological, right? So worry coming and going, totally normal. Often for people that increases around the time of medical appointments, especially scans, but worry that is kind of constant and, not remitting at all might be more, interfering and suggest that there might be something more there. Next slide. All right, and finally, when we think about depressive disorders, kind of the other class here, symptoms of depressive disorders also fall into kind of two categories. First, I think it's important to acknowledge that sadness is a normal and expected part of cancer and cancer survivorship, right? People might feel a sense of loss or grief around their health, about the life that they had before, what they imagined that their life would be. But sadness that kind of doesn't remit, right? We might start to look more into that. So can be characterized by emotional symptoms, sadness that won't go away, little interest or pleasure in doing things, feeling emotionally numb, worthless, hopeless, suicidal ideation, of course. And then there also may be some somatic symptoms, things like fatigue, sleep problems, and weight gain. Advance the slide, please. There you go. I put some stars there because I think that it can be really difficult, especially in cancer survivors. You'll see that those somatic symptoms are things that we often see in the context of cancer and treatment. So it can be really difficult to pinpoint kind of what may be related to depressive symptoms and what might be related to kind of disease treatment and pathology. Prevalence of depressive symptoms ranges from 8 to 25%, but the rate of actual kind of diagnosable depressive disorders like major depressive disorder is about 13%. Important to note that this is about 4 times the rate of the general population. So this is a really big issue and something that we really should be screening our patients for regularly. Risk factors for depressive disorders are pre-existing mental health issues, a lack of support, and a lack of adaptive coping strategies. One more click. And the reason it's particularly important for us to look at depression, especially, is because it is associated with worse treatment outcomes, worse quality of life, and increased risk of mortality. Next slide. So what can we do about this, right? I think these are some kind of practical, hopefully easily applied strategies when we think about helping people to manage distress and promote adaptive coping. The first one is just to screen, right? So screening helps us see where people are at. So we can use the distress thermometer. We could also use brief tools like the PHQ or the GAD. I think normalizing emotional ups and downs is really important. Assessing patients' coping resources. So what do they do to cope? Do they have adequate social support? and then encouraging people to engage with those identified sources of support and coping, making sure that people are still connecting with their values and the things that make them, right? Treating physical symptoms and side effects. These can be a really a primary contributor to psychological distress. If people are in pain or really fatigued, and we have good treatments for those. Recommending practicing healthy lifestyle habits. We know that taking care of our body helps us to take care of our mind. Pointing people to trusted cancer resources, which I'll show some in a moment. Referring to psychological support resources when indicated, and then also advising the thoughtful use of the internet as a tool, which I'll talk a little bit more about in a moment as well. Next slide. I love this acronym to help us remind us, back one, how to take care of the body and mind. So please, one forward, please. Up. I don't know why it's jumping over. There we go. Nope. Back two. There we go. Great. So please is a nice reminder of the importance of using strategies, healthy lifestyle practices, how this is kind of a first line of defense against psychological distress and mental health difficulties, because when we are taking good care of our body, we are better able to manage our emotions, cope with stress, manage and cope with cancer-related side effects and treatment effects, and just feel generally as healthy as possible. So the acronym's a little bit of a stretch. You'll see the underlining here. But first, treating physical illness, right? So taking care of your body, going to medical visits, taking medications as prescribed, balanced regular eating throughout the day, avoiding mood-altering substances, getting adequate sleep, that amount that feels good for you, making sure your sleep environment is, conducive to sleep, cool, comfortable, dark, and then movement. So trying to get some exercise, move your body every day, pacing yourself, even if you can't do much, right? Encouraging people to do what they are able to do. All of those things are going to help them to cope and to feel better. Next slide. Psychosocial support resources. So there are many different resources that cancer survivors might turn to. Therapy can be a really helpful place to process emotions, develop coping mechanisms, and navigate challenges. Support groups, a lot of people really like these for kind of relating to other people with shared experience and learning from one another. Mind-body interventions like mindfulness or relaxation exercises can help to manage stress and symptoms. Psychoeducation, so kind of learning more about cancer treatment and coping strategies. Social support from friends and family, and then pastoral care if that is relevant. Next slide. When we're thinking more about diagnosable anxiety and depressive disorders, the gold standard would be psychotherapy plus or minus pharmacotherapy. There are lots of evidence-based psychotherapeutic interventions that have demonstrated efficacy in cancer patients and survivors. You see all those listed on the left here. The pros of these are that they are unlikely to have kind of physical side effects, and they might be more likely to kind of address the root cause. But cons can be, time and resource intensive, and they might be harder to access, and timing, right? If a person has a lot on their plate, it might not be the best time for them to jump into therapy. I am a psychologist, not a psychiatrist, so I do not claim expertise in the psychopharmacological interventions, but I think it's important to acknowledge that these are really helpful and useful for many patients. I know that, community providers have varying levels of comfortability prescribing these agents, and I often think that a person's kind of primary care provider is probably the best person to prescribe these things because you have ongoing regular contact with them and continue to monitor their use of these agents. These are great because they can help quickly. They're often very cost effective. They might actually have added benefits beyond just mood. So things like mirtazapine can also be helpful for appetite and sleep. Cons can be side effects, and that some of these do interact with cancer agents. So just important to note that. Next slide. Here is a very non-exhaustive list of cancer resources, but I think these are trusted resources you can always point somebody to. The NCI, American Cancer Society, some more in the bottom right-hand corner. There's also many disease-specific resources, so you might encourage a person, say with prostate cancer, to seek to go online and kind of look at some national organizations that are devoted to prostate cancer. Next slide. And then kind of more pressing and common question now, I think patients are increasingly turning to things like AI to search for answers about cancer symptoms, side effects, treatments, et cetera. So this was a recent publication just in the Cancer Letter, which is a newsletter actually last week that showed kind of what people are using AI for. You'll see the most common applications are looking for suggestions for side effect and symptom management, treatment options and clinical trials, and survivorship follow-up and lifestyle. Generally, AI has many of the limitations of the pulling from the general body of knowledge online is that it is not, vetted by a medical professional. So there is the risk that people are, receiving feedback that is misinformation or not totally accurate or up to date. So some general kind of comprehensive guidelines for healthcare providers are to proactively engage with patients about their online information that they're receiving, to make sure that you have educational evidence-based sources to point people to, and to advocate for safe, validated AI tools, which I think are being developed as we speak. Next slide. All right. Oop, that's jumping into the case study. So I will pause now and see if anybody has any questions.
Dr. Hyland, Sonia, I don't see any questions in the chat currently.
Trying to get off mute. Okay. Holly, thank you for that. And I was trying to think of some questions that we could possibly think, but in the area of research that still may need more attention for supporting survivors' mental health, is there, in what you're seeing in your research, is there something that's coming, something that's needed for patients? And then let me ask you too, it's a two-part question. I apologize now. In the world of public health, when we think about survivorship, we're thinking folks who have patients that were just diagnosed, to those who, the older definition of survivorship was they survived 5 years out. So those who maybe are in remission or are currently getting treatment. But again, going back to the original question, what do you foresee is on the research forecast for these patients and their needs, and how, I'm going to go to a next question being what type of policies could we be looking at? But let me stick with my original question. Sorry.
Yeah, good question. So this is, stay tuned for my case presentation. Actually, I'm going to revamp your definition of survivorship here, and I'll talk a little bit about this in the next portion. But the National Cancer Institute has made a really big push to have the definition of a cancer survivor be any person who is diagnosed with cancer through the balance of life. And the reason that is important is because, cancer survivorship and often the kind of challenges associated don't end with active treatment. And especially because as people are living longer, they may be more likely to kind of experience more effects. And those things might happen right after, they might happen far after, right? That is really important to kind of capture everyone in that definition. And so that figure that I showed, that 18.6 million, includes anybody who's ever been diagnosed with cancer and is currently living in the United States. I think that's also important for policy, right? Because when we're thinking about how do we kind of meet the needs, this is a huge number of people. And so we need to be able to provide kind of ready access to resources that are cost effective and accessible to everyone. And so I think that there's a lot of research of mine and other people's that are really trying to do that. So how do we get psychosocial support services to everyone, whether it be using apps or telehealth or other platforms that can make things more accessible. We know I am a psychosocial oncologist, right? There are not many of us. And so there are not enough clinicians to kind of meet the demands and the needs of this huge growing population of people. And so we're looking at models, right? So can we have master's level clinicians be the primary providers of this care? Can we even have health coaches, right? Kind of bachelor level people who can deliver some of our effective interventions. These are all things that are being researched right now.
Thank you for that. Okay. All righty, we are at the 12:31 hour, so if there aren't any more questions for Dr. Highland, I have more, but I'll email them to you and share with the group. But for the sake of time, let's go ahead and let you proceed with the case study piece. And let me get that back on the screen.